Hello everyone, welcome to NeuroLab YouTube channel. Today Daniel and Arvin are honored and excited to have Professor Mari Bakitas as our guest. She is international renowned scientist in palliative care. She is also professor and associate director at the Center for Palliative Care at the University of Alabama in Birmingham.
Thank you, Daniel. Hi, everyone. And of course, thank you, Daniel, for your invitation to be here at this interview with Professor Bakitas, my dear professor. And at the beginning, I am pleased to start by your permission, Professor. Let me start the questions. The question one. The question one is about the meaning of palliative care. What is palliative care and what is interesting about it for you? And of course, why do you think palliative care is essential for our whole population in the world?
Thank you so much for inviting me to talk about the topic that is of great passion to me. As I'm sure many of your audience know, palliative care is a medical specialty that helps to improve quality of life of people with serious illness and their family caregivers. It is a multidisciplinary team approach to reducing suffering in all aspects of quality of life, and also is and should be available to anyone at any stage or any age with serious illness.
Thank you. I study psychology, and it is interesting for me that to know, have you collaborated with psychologists in your studies?
Absolutely. The funny thing is that at my prior institution, when I was still quite young nurse and clinicians primarily, I connected with a psychologist. His name is Dr. Tim Ollis. He is still the head of neuropsychology at Memorial Sloan Kettering Cancer Center in New York City. And because I was not in a school of nursing, but in a cancer center, I didn't have any nurse scientist mentors or colleagues. And so he was my primary colleague that I began working with. Dr. Ollis' interests were in pain and symptom management, and as were my interests as a clinician only. And so over the years, I served as a clinical partner for him to help with identifying some of the problems in cancer care, and also to help with recruiting patients. And so we created a team between us. And so my first interactions and work in palliative care was teamed with a psychologist, and in that world of behavioral science and psychology, as opposed to nursing science.
It's very interesting collaboration between multiple disciplines. Could you please explain about how a psychological intervention can help people in palliative care setting?
I don't think we actually know enough about the mechanisms of how palliative care works. I think for physical symptoms, we have physiological mechanisms that we can rely on to understand, not completely, but better, how certain drugs work. However, when it comes to psychosocial interventions, it isn't really clear whether there is a direct impact, and we've actually written a paper on this, of whether it's a direct effect or indirect effect through symptoms like depression or anxiety, for example. So we wonder if our intervention improves quality of life because maybe we reduce or help treat depression or anxiety, and that's how quality of life improves. Similarly, does our intervention help increase social support, and is that the moderator of how quality of life improves? So I think it's a very good question. I don't think we have a complete answer, but certainly we know that psychological interventions are a very key aspect of improving quality of life for people with serious illness.
Thanks.
So let me ask another question from you, Professor, here to continue our intervention, and it's about the challenges of palliative care studies. What do you think the challenges are, and could you just explain some more detail about it?
Well, I think the challenges of palliative care in general, clinically being implemented, is that our society often focuses on cure. And for some, cure and palliative care are sort of different goals. World Health Organization, a long time ago, back in the early 90s, proclaimed that care and cure should go together. So palliative care and disease-focused treatments should really go together. I think we've made a lot of progress in promoting that opinion and promoting that philosophy in care, but not entirely. And so, again, I think some of the challenges clinically are that they're seen as a dichotomy. You do one or the other and not both at the same time. So in palliative care research, we have that barrier to overcome in terms of getting our clinician colleagues to refer patients because they might see that being part of a palliative care study is the same as giving up on disease-oriented treatment. And so, we have that barrier still to overcome. I think that's probably the main challenge for that. I guess another one possibly is because it's still a very new field, palliative care is. And in some areas in different countries, it's still even newer than it is in others. And so there's sometimes misunderstanding. Right? So not only is it not well accepted that palliative care is something that can be done for, as I said, any age, any stage of illness, concurrent with disease-oriented treatments. But for some, they see palliative care as reserved only for people who are at the very end of life. What we know about that is that palliative care offered early on provides an opportunity for patients and their families to be able to learn skills and understand ways in which they can be in charge of how their treatment goes, or that their treatment is part of or consistent with their own personal, cultural values and beliefs. And so reserving palliative care for only the end of life really shortchanges patients and families from the full benefit. So I think those are probably the two biggest challenges.
Thank you. And as you mentioned, the aim of palliative care, the whole aim is to increase the quality of life of patients and both the caregivers. So let us move forward to Enable program and a little talk about the Enable program. How did you what inspired you for developing this program?
Mm-hmm. So, as I said, I've been doing this a long time. I'm very old. And in my younger days as a clinician, I was working in cancer research, caring for people who are undergoing investigation treatments, and specifically bone marrow transplantation. And cancer research, providing care in those settings is always very exciting. There's a new drug or a new kind of treatment, and everyone's very excited about it. But as we know, at least when I was working in transplant, only a third of the patients were actually cured of their disease. Now that leaves 2/3 of the people who are not cured of their disease, and there was certainly not as much excitement about what was seen as failure. And so people who weren't being cured were sort of to the side or invisible in many ways, and not much attention. And as a nurse at the bedside, seeing this was very distressing, to witness suffering that we weren't treating as well as we possibly could have. So that was really, for me, the major impetus was to say, well, why aren't we doing, our most aggressive caring similarly for people who are not cured of their disease, which is the people in the majority. So that was, kind of early on. And then there was a call for demonstration projects in this new field called Palliative Care. And so we came up with the idea that similar to childbirth, where if you know you are going to have a baby, you don't wait 8 months and 29 days before you say, oh, maybe I should start preparing. And so we took that inspiration from, early obstetrical care to say, if we do something when people are newly diagnosed with an illness to prepare, then maybe things will go better towards the end of life. And that was really the whole motivation for Enable. That is an acronym that stands for Educate, Nurture, Advise Before Life Ends. So we were saying, yes, we need to do something. Now, we weren't sure what, but we did some interviews with patients and families and clinicians and said, what do you wish you knew when you were diagnosed that would have helped you to do better with your illness? And so where Enable came from was directly patients, families, and clinicians telling us, well, we wish we knew more about expecting and managing symptoms. We wish we knew more about communication, how to communicate with our clinicians better. And so all of the different coaching strategies put into Enable came directly from patients, families, and clinicians.
Thanks.
Thank you.
Thanks for your interesting explanations about the Enable program. I want to know how Enable can fulfill patients' psychological demands.
Mm-hmm. So again, each of the coaching sessions is directed at one of the 4 essential elements of palliative care: physical, psychological, social, and spiritual. And so really assessing where patients are in terms of their coping, whether there's issues of anxiety, depression, and, helping them to deal better with the stress of serious illness. Because we don't believe that everyone who has serious illness is going to, have sort of pathological diagnosed conditions or symptoms of, true depression. It's really about dealing with the stressors of serious illness. We all need help with dealing with daily stress. And so that is how I see psychology and the elements of it deal with one aspect of total holistic person care.
Many thanks.
I think that's that.
Arvin, I know you had a good collaboration with Dr. Bakitas. Could you please explain about your research?
Everything goes back to February 2021. I was studying for my thesis, and I like to study on palliative care. And I was reading lots of articles at that time, and because of the COVID pandemic, I was trying to find a way for conducting a tele method for palliative care. And at that time, in PubMed, I was searching, and suddenly I find a paper. I know the exact day, September 2020, the JAMA. It was a very great article from Professor Bakitas, and I read all of it. And after that, I think I was thinking that there's lots of things behind this, and I started to read all the papers back from 2004, I think. Am I right, Professor? 2004, I think. I read nearly all of the papers about the methodology and how everything modified during the years and how everything changed. At that time, I really enjoyed the whole methodology and whole the program, so I emailed the professor and asked her about some advice, and also asked her if she could send me the guidebooks of the program. And she sent me the books, and 1 second I was talking to myself that, okay, let's just ask her if she could be my thesis advisor. And she said yes. And I think at that moment I was the happiest man in the world. And we started our working together with her lovely team. And I should mention their names, Dr. Nicholas J. Adam and Dr. Rachel Wells. They really help us during my thesis program, and we published our study protocol 6 months ago, and now the main article of my thesis is under review. And also, beside all of this, by permission of the Dr. Bakitas, we started the cultural adaptation of the Enable program for heart failure patients and their caregivers for Iranian population. And we are in the middle of the program, and we are going to start sampling. It's a qualitative, and we are very enthusiastic to start the program, to continue the program.
It was very fascinating experience, and I can predict that your expertise and your studies can be valuable for many students in Iran and all around the world. Can you talk about some suggestion for early career researchers in palliative care or another fields?
I remember the day that you reached out to Arvin, and I was like, wow, this is amazing. Somebody in Iran, thinks this might be a good idea to do there. And so, we were very excited on our team side too, because, our motto is palliative care for everyone, everywhere, all the time. And so this was an opportunity to work cross-culturally. Someday I hope to visit. Someday I hope you visit here. And our work has been expanded also to Honduras in South America. We have colleagues that are actively working with us in Singapore and also in Turkey. So it's very exciting. I have all of my guidebooks that have been translated into all these languages in my office, you know, and very proud to see this work has expanded. But it is a team, and we are very excited and enthusiastic about welcoming students of all kinds, early career people. And so I say that, you know, like you and Arvin, as early career people, is, you know, just reach out to people who are more senior. I would say, especially in our field, you know, most people that you reach out to will be very receptive, and you know, we want to keep the field going and growing, and that's not going to happen unless we do some succession planning and we bring in all of our early careers, people's talents and enthusiasm and energy to make sure that this work continues beyond, you know, just our old decrepit people's.
Thanks for sharing your valuable experiences and knowledge. It's my honor to having you in this session.
Thank you very much, Professor, for your informative talk.
Thank you. Do I get to ask you one question?
Sure. Which of us?
I guess I'd like for you to answer. So tell me that, you know, in our lives and society and all today and culturally, what is it that keeps you motivated and you going when, you know, you face challenges and hardships and so forth in each of your pursuits?
Daniel, will you start?
I'm not sure that gets your question correctly, but my motivation to do my works is that I'm interested in pain and psychological intervention that can modulate pain. And I study on hypnosis, effect of hypnosis on pain. And when I saw your paper with Arvin, it's make a question in my brain that how can contribute psychology and palliative care, and this is my story.
And well, about your question, Professor, as you know, we are in a hard days, and the thing that it keeps me motivated is just one thing, and as I said and told you before, is that the helping, to help, to be positive and talk to others, to motivate them for being a better person, for trying to make patients less suffer, any kind of symptoms, signs and symptoms. But the main thing that motivates me is to be helpful to others. And this keeps me motivated. And I learned this from you very multiple times.
Well, I'm glad we're here to be inspiration to each other. And, you know, one of the things I just want to say to you, Daniel, specifically as a psychologist and your interest in neuropsychology specifically, you know, both Dr. Alice and I were very focused on the physical symptoms And even as a psychologist, he was very interested in pain. And so as we kind of in parallel paths grew, not only just, the sort of physical aspects of pain, which he has done an extreme amount of research in cognitive behavioral therapy and central nervous system aspects of pain. And my focus was more on neuropathic pain, and so neuropathy. And so together, he was the central nervous system guy, and I was the peripheral nervous system person. But together, we were also beyond just the physiologic aspect. How do you cope with this? Because at this point, many pain syndromes, there are not cures for. So it sort of led to this coping piece. And so I think that for all of us, although it's important to dive deep and learn mechanisms, also to always keep the person and the whole person in mind, especially when cures are possible, is a really critical aspect as you go forward with your study. So anyway, thank you for asking me to speak to you today. And I look forward to our continued collaboration.
Thank you too, Professor.
Many thanks again to accept my invitation to this session.